आता होईल सर एका मिनिटात.
मिथुन handsome लगता है.
He is always handsome sir.
ऐसा डायलॉग मारेंगे तो अपने को रिप्लाई भी नहीं पता.
I think we are live now.
Yes.
Oh, hi, how are you? Hi sir.
We are live sir.
Sridhar, hi.
Hi.
Sir, hi sir. Good evening, sir. Good evening.
Hi, sir. Good evening, sir.
Good evening. Good
Please
evening.
go ahead, Sridhar.
Yeah, okay. So, good evening, everyone, and thank you so much for all the presenters and expert talk and moderators for this April IS webinar today. So, today we have an eminent speaker, Dr. Milind Pimprekar sir from Nashik. He is going to speak on pearls in PCL reconstruction. Then we have followed by two case presentations by Dr. Rohit and Dr. Ajinkya. So today's whole webinar is going to be moderated by two expert arthroscopy surgeons, one Dr. Miten Seth from Mumbai and Dr. Mohan Kumar from Bangalore. So we'll go ahead and start the webinar. Over to the moderators. Thank you.
Right. So we are very lucky to have Milind Pimprekar sir today present his experience with the PCL. Sir has published recently and previously on his techniques, and I'm personally also looking forward to sir's presentation. Thank you, sir, for agreeing to present on this topic, and we look forward to what you're going to share with us.
Thank you, Miten. So it begins with me. So should I share my screen?
Yes, sir. Yes. Please.
What's happening?
Sir, I think you went on to the last slide now. You
Okay.
need,
Let me just check.
sir, cancel it, sir. Just
So you can press escape and then scroll up
F5.
to the first slide.
Yes.
That's the advantage of having, techies there. All
Yes.
right. Is that okay now?
Yes, sir.
Perfect.
Yes, sir.
Perfect. So thank you very much again, Sridhar, Neha, Sandeep, and Miten, Ajinkya, for this opportunity. So PCL, once upon a time, used to be a hot topic of discussion, and there were a lot of meetings where the technical pearls for PCL were discussed. As it is, isolated PCL injuries we know are not very common. In our country, we do get a lot of PCL avulsion cases than isolated PCL injuries. Usually what we have is a combined injury of a posterolateral corner in a multi-ligament scenario. Today, we are going to discuss about isolated PCL because that's what is being told to me. So whenever we think of doing a PCL reconstruction, I think we should always revisit these points, and we must always revise this in our minds before we enter the operating room. That is, what is the biomechanical importance of PCL in the human body? How does the arthroscopic anatomy look like? Whether we should do a single bundle or a double bundle PCL reconstruction? What are the advantages and limitations of single and double bundle PCLs? And what are the different techniques which we use? For example, are we going to use the posteromedial high and low technique? Are we going to use a posteromedial posterolateral technique? Because I personally feel that the PCL is a posterior ligament and the posterior work should be done posteriorly. So if you're doing it posteriorly with posteromedial and posterolateral portal, I think things they become much more easier, and that's my preferred technique when it comes to PCL reconstruction surgeries. So let's go point wise to understand what is the biomechanical importance of this very strong ligament, or the strongest probably ligament in the body. So the functionally PCL is primarily restrained to the posterior tibial translation at all flexion angles. It is also a primary internal rotatory restraint beyond 90 degrees of flexion, and it also functions as a supplementary restraint to external rotation beyond 90 degrees. And with the recent biomechanical studies, now we know that the posteromedial bundle comes into play when it comes to restraint of external rotation beyond 90 degrees of flexion. Historically, as we all know, it was thought that the anterolateral bundle and posterolateral bundle, posteromedial bundle, I'm sorry for that typo, have reciprocal functions, with anterolateral bundle functional in deflection and PMB functional in extension. Contrary to this, the recent biomechanical studies have suggested that these both bundles, they have a codominant role, meaning both the bundles are active and work together in unison to resist the posterior translation of the tibia. Thus, both have significant role in absence of each other. So does that really make sense of reconstructing only one bundle and leaving the other alone without having a proper knee kinematics restored if you're doing a single bundle reconstruction, and forms the basis to debate regarding whether it is single bundle or a double bundle PCL. So biomechanically, a strong ligament which helps resist the posterior translation, and it also resists the rotations beyond 90 degrees of flexion, is the biomechanical function of the PCL. Now, when one decides of doing a reconstruction of the posterior cruciate ligament, we should be aware of arthroscopic anatomy of the PCL. The gross anatomy of the PCL everyone knows, but then we must also understand how does the knee look like on arthroscopy when we think of doing a PCL reconstruction. So PCL, as one can see, has got an attachment onto the medial femoral condyle. It's a broad, concave and semicircular area along the intercondylar notch. The PCL inserts into a depression just inferior to the joint line onto the tibia, between the tibial plateau and posterior to the tibial spine. Now here also the PCL has got both the bundles attaching at different locations. But even if you're doing a double bundle PCL, your attachment onto the tibial side remains the same. And that probably is the basis where we have shifted from 20 millimeters below the joint line as a tibial footprint to about 15 millimeters when it comes to reconstructing both the bundles or doing a single bundle PCL reconstruction. So these are the bundles of the PCL. You have anterolateral bundle, you have the posteromedial bundle. These are two distinct, but they are inseparable bundles. So there is an imaginary split or artificial split between the two bundles. The bundles naturally are named by their position within the femoral footprint or attachment, the anterolateral being anterior and a posteromedial in a 90 degrees of knee flexion would be inferior towards the tibial plateau. And this arthroscopic anatomy one needs to understand when we actually do an arthroscopic PCL reconstruction surgery. So this is the femoral attachment. Here you can see, if you consider a clock-like position, then this is the 12 o'clock position. And the anterolateral bundle starts at the 12 o'clock position and it extends below down here. It comprises about 55% of the whole footprint, whereas the posteromedial bundle comprises about 45% of the whole footprint. This posteromedial bundle is flanked by two ligaments, which are meniscofemoral ligaments. That is the anterior meniscofemoral or ligament of Humphrey and posterior meniscofemoral ligament of Risberg. These ligaments are inconsistent and may not be present in all the individuals which we operate. So if you have a closer look at the femoral footprint, this is how it looks. So at 90 degrees of knee flexion, it starts from the trochlear point, and that's the attachment of the anterolateral bundle. That's the attachment of the posteromedial bundle, and that is what is called as the intercondylar ridge. This W indicates ligament of Risberg, which is an important ligament running from the lateral meniscus, and it also plays a role in preventing the posterior translation. In a dissection, this is how it looks like. So anterolateral bundle is attached on the superior aspect of the intercondylar fossa. This is called as the champagne glass drop-off. We will see that in forthcoming slides. and this is the posteromedial bundle here, which goes down and attaches onto the inferomedial aspect of that trapezoid-shaped socket which you have on the tibial side. This figure is very important to understand because you'll see that anterolateral bundle is just kissing the articular cartilage. It is just about 2 to 3 millimeters away from the articular cartilage, whereas the posteromedial bundle is about 4 to 5 millimeters away from the articular cartilage. And these landmarks one needs to understand while performing a single bundle or a double bundle PCL reconstruction. So this is again an enlarged picture of the same. One can see the intercondylar notch there, that is the ridge. Then you can see the anterolateral and a posteromedial bundle. And this is what is the champagne glass drop-off. So whenever we are doing, I'll go a step further and say that doing PCL avulsion surgeries, we can easily identify this champagne glass drop-off. And more often than not, the PCL fragment is avulsed superior to champagne glass drop-off. And you have to drill holes if you're doing all arthroscopic repairs below this drop-off to get the trap door going and getting fixed there. So this anatomy one would easily get to know, and one should, I think, try and see every time you do a PCL avulsion or a posterior surgery to identify these anatomical landmarks. Meniscofemoral ligaments, as we said, are important ligaments. The anterior meniscofemoral ligament of Humphrey and the posterior one is Risberg. These meniscofemoral ligaments, they run from the posterior horn of the lateral meniscus to the lateral aspect of the medial femoral condyle, and they are named in relation to the posteromedial bundle and are important and should be saved in whichever case you find them. So that's the diagrammatic representation. That's actually the posteromedial bundle, and that's the posterior Risberg, that's the lateral meniscus. You get to see this ligament very well when you are dealing with zip lesions of the meniscus, lateral meniscus. If you see zip lesions of the lateral meniscus, and if you see that the Risberg ligament is missing there, that indicates that this is a very unstable kind of scenario as far as the lateral meniscus is concerned. And that's one indication where one must always repair the zip lesions. And that's the ligament of Humphrey. So arthroscopically, Laprad's picture, again, a very famous picture and wonderfully picturized here. So those are the things which we need to really understand. So that's the highest point of the trochlea, that's the trochlear point, and the anterolateral bundle runs from the trochlear point to the medial arch point. And this is the area which is actually the anterolateral bundle. Then this is the posteromedial bundle. You can see the distance of ALB from the articular cartilage, and you can see the distance from articular cartilage of the PMB. So posteromedial bundle is flanked by ligament of Humphrey and Risberg. And this visual impression one should always have whenever we are doing a PCL reconstruction arthroscopically to really understand where to put your tunnels. This is what you see, again, a Laprad's picture in an arthroscopic picture at 90 degrees of flexion. That's the trochlear point there. That's the medial arch point, and you see anterolateral bundle here. So when you're viewing actually through the anterolateral port, this is what you're going to see onto the medial femoral condyle. And there you're going to place your tunnels for doing your PCL reconstruction. Posterior point is a point which we normally see whenever we are doing medial root repairs. And these are the posteromedial fibers of PCL where we have to nibble them or shave them a bit to really have a good look at the posterior aspect. At the same time, when we are going into the posteromedial compartment for seeing the ramp lesions, in that situation as well, at times, you will have to shave some fibers of the posteromedial bundle. And every time you do that, you should see the anatomy of the PMB and the anterolateral bundle of the PCL to understand and get your basics perfect when you do the surgery. That is actually how the PCL looks like. And that is the o'clock position with two arrows which you see. That's the 12 o'clock, and that's the 1 o'clock position onto the left knee, if you see that. So if you see the anatomy of the PCL, then that is the ACL. That's the PCL coming up from there. In between them, you have a septum, and you have to create one window there when you're doing a PCL reconstruction. So those are the fibers. That is deskeletonized PCL, and that is the attachment onto the medial femoral condyle. You can see that's the posteromedial bundle. That's the anterolateral bundle. Posteromedial bundle is a little away from the articular cartilage, whereas the anterolateral bundle is kissing the articular cartilage. Now, if you move your probe, you start with the trochlear point there, and then slowly you come down to the medial arch point and the posterior point I showed you a little while ago. When you're doing this, and if you're doing a single bundle, then you need to hit the center of the trochlear point and the medial arch point, and probably it is there. Now here you put your the reamer, the definitive reamer, to understand how much away you need to go from the articular cartilage, and that probably will give you a single point for a single bundle PCL reconstruction. So every time you're doing this, you can see this anatomy and revise your anatomy in that situation. On the tibial side, as we know, this is the largest ligament, and the course we already know. It is named due to its insertion of the posterior aspect of the proximal tibia, and there you see the insertion. That's the joint line. That's the anterolateral bundle, which is superolateral, whereas the posteromedial bundle is inferomedial. Now, if you're doing a single tunnel, you're going to in the center. So this probably is the 20 millimeters, and this mark is about 15 millimeters. So now, at least for me, I have started shifting my single tibial tunnels onto the 15 millimeter mark, which makes life a little more easy when you do this. And the visualization also becomes much more easier. So tibial insertion, as we talked about, is in the trapezoidal fossa, and it is wider inferiorly. The anterolateral bundle is attached to the superolateral aspect I told you, and these two bundles can be identified by their different slopes as well when you're doing arthroscopy. And these bundles are distinctly visible when you take the posterior ports. That's again a beautiful picture, Laprad's picture here. What we need to understand arthroscopically is you should identify this shiny white fibers. These shiny white fibers are attachment of the posterior root of the medial meniscus, and they can be easily demonstrated when you do a posterior arthroscopy. So there is a shiny white point, there is a lateral cartilage point, and that is the situation of the anterolateral and the posteromedial bundle. You can see the PMB is very wide inferiorly, and the champagne glass drop-off is inferior to the posteromedial bundle. So there is no need to go up to champagne glass drop-off. You can just identify the white shiny fibers, lateral cartilage point, and have your tunnel going just in the center of both the bundles, which probably would be about 15 millimeters from the joint line. So here, another tip to understand is one might see the brown fibers of the popliteus muscle, which indicates that probably you have reached the right place. So again, the same insertion point. That's how the jig looks like. That's the 15 millimeters mark, and that's where I'm going to come out for my individual or a single tibial tunnel. This is again a radiographic study done by Laprade group itself, and that's a wonderful picture. As those who are beginners, they can start with the image intensifier intraoperatively to understand where your bit pin should exit posteriorly. And this calculation is the champagne glass drop-off, which you see. And if you want to have a center of the PCL attachment between ALB and PMB, that's a 45 degrees angle, which we have to take and point it towards the champagne glass drop-off. Have an image intensifier control there to understand that probably your bit pin is reaching in the desired direction. Although as you get used to doing these surgeries, the image intensifier step is absolutely an optional. But I would recommend for the beginners that if you're doing this and checking it that you're at right place would always make a sense to prevent from going wrong. So I'm looking from the posterolateral portal, and these are the shiny white fibers. Can you see them? And you can see here that you are not too far off inferiorly. That's probably the place where your tunnel is going to come, and that's the tunnel which is coming in. So I preserved the PCL fibers there and created a tunnel. So these white shiny fibers are very, very distinctly visible. You should preserve them. You should not injure them, because that will make your medial meniscus root unstable. So again, to show you, those are the white shiny fibers, and that's your medial meniscus there. That's probably a little scuffing into the notch, but that's your PCL coming in, and that probably will be your tibial attachment. So with these arthroscopic anatomical points, that's how probably I do my single bundle PCL reconstruction. That's the reverse Lachman's, as you can see. It's a PCL deficient knee, and the classical sign of PCL deficiency arthroscopically is called as sloppy ACL sign. That's how it looks. That's the ACL. It looks absolutely sloppy. At 90 degrees of knee flexion, when you give an anterior drawer and a posterior drawer, you'll see that the ACL getting sloppy and straightening out with anterior pull onto the tibia, indicating that the PCL is deficient. And when I was learning this point was very much stressed by my seniors, that looking at this ACL does not mean the patient has got ACL deficiency, but this is a sign of PCL deficiency. And it probably would be criminal to reconstruct ACL in such patients, thinking that it's an ACL injury. Technique-wise, in a single bundle, graft choice can be different, but I do by posterolateral and posteromedial port. To begin with, this is a patient with both ACL and PCL injury. So that's the first window which I create. When the ACL is there, this is created between the ACL and the PCL. That is the septum which is being shaved. You create a window in the septum and see the posteromedial compartment from this. Here you can switch your shaver and your scope to get a direct trajectory to the septum. Then you go on to the posteromedial compartment, and at the synovial fold, push in a needle, take a 11 number blade, create a nice portal there. With an artery forceps, you dilate the portal. And once you dilate the portal, then one can take a Wissenger rod or switching stick from your shoulder set and then push that Wissenger through the septum, which we have created a window in. So that's the hemostat coming in. That is the switching stick. Now here I go posteriorly through the septum and kiss the lateral condyle. If you kiss the lateral condyle, you will come out somewhere superior and you'll miss the common peroneal nerve there. So you're going to face little superiorly and posteriorly so that you don't come out near the common peroneal nerve. Now your life becomes very easy. My shaver is coming in from the posteromedial port. I am seeing through the posterolateral port, and my shaver tip is facing towards the PCL. So when I'm doing PCL reconstruction, my shaver tip is always towards the PCL. Then one can take radio frequency and you can see that's the fat there. Once this fat is visualized, you know that probably you're reaching the PCL footprint onto the tibial side. And that is the white shiny fibers there. That's the medial meniscus. If I dissect here, I'll see the white shiny fibers, which I don't intend to do, but that's the position. That's the lateral cartilage point somewhere here. I have not shaved this. If I shave this, I'll be in a position to see the lateral cartilage point to understand what is the width of the PCL. Once you see that, you switch the port again. And now to create a tibial tunnel, come with the PCL jig and pass in between the ACL and the PCL if ACL is present. If ACL is absent, as in this case, and go into the posterior compartment. That's the 15 millimeter mark. Again, I switch my scope into the posterolateral port, and under vision, I drill the tibial tunnel. Now you can see the Wissenger rod coming in from the posteromedial port, which pushes the capsule posteriorly, which prevents the injury to the neurovascular structures there. Now here, as the bit pin comes out, my jig is protecting itself, but we are coming up with a very nice paper giving you the calculations as to how much length of the bit pin is to be kept while drilling, which will prevent it from moving into the posterior compartment. And you will very soon read that paper. So here you pass the bit pin and place your shuttling suture into the posteromedial compartment. Here your job on the backside is over now. Once this is done, you shift your scope to the anterolateral or anteromedial port, and then you pay attention towards the femoral footprint. Once you have done this, I think I've missed something in process. Okay. So the shuttling of the suture, now we shift to the femur. Now there you can see I'll be marking the areas there, and that's the area where I need to go if I'm doing a single bundle. You can see the trochlear point here. You can see the medial arch point there. So with a reamer in, I pass the bit pin, probably taking into consideration that I want to be near the articular cartilage as possible. I use a suspensory fixation onto the femur side, and I use a screw onto the tibial side. So you do in the same way as you do it for the ACL reconstruction. You measure the tunnel length, drill with 4.5 millimeters, then with a definitive reamer. That's the shuttle suture. And once you have shuttled the suture, you have to take care of the killer bend. So in this situation, either you can go back posteriorly, or you can even try and give a push from the anterior port where you can pull the endo button in from posterior to anterior. When we see the double bundle PCL, there is another way where you can pass the graft into the femur first and then shuttle into the tibia to avoid the concept of killer bend. So my probe is being utilized as a lever, and I'm levering out those shuttle sutures from the anterior ports itself. Once you do that, you see the endo button coming into your site and then pulling that into the femur. So that's how you can manipulate and pull the graft into the femur. Once you have pulled it at the desired length, you flip it onto the femoral cortex, onto the medial femoral cortex, and then in this case, fix it onto the tibia with a screw. That's the ACL, which was done later after the PCL was done. And this is a soft tissue preserving PCL plus tibial footprint preserving ACL performed as a single bundle with a bucket handle, medial meniscus tear, and that's the medial meniscus repair to end the procedure. So single bundle for me, the graft choice, individual choice. Presently, I'm using peroneus longus. Then the fixation on the femur is always a suspensory fixation. On tibial side, I use a screw, which is a bio screw, and I usually use that as near the tibial tunnel as I can. And that's the final picture. Now, if you think of a single bundle, we can conclude that although double bundle is biomechanically a superior option, but single bundle yields the same results with no significant difference in long-term outcomes. Posteromedial and posterolateral portals allow a better visualization of anatomy and safe dissection. Graft choice can be surgeon's preference. So what are the advantages of the double bundle? So what is it all about? So one of the biggest controversies concerning PCL, single bundle or double bundle, is what the biomechanical studies we saw. And the proponents of double bundle, they say that they can restore the normal anatomy and native knee kinematics in a better way if they do a double bundle, as with recent biomechanical evidence. So that is how the double bundle happens. You can see that if you're doing a single bundle, that's probably the center of the ALB where you're going to do it. And you're going to cover only this much area of the footprint, whereas this area is left alone. But this is the anterolateral bundle, which you can see. If you're doing a double bundle, then probably this is the area which you're going to cover, which is the anterolateral and a posteromedial bundle, which is much more larger footprint, and you're recreating the native anatomy according to the recent biomechanics. So those are the two bundles. That's the trochlear point, that's the medial arch point, and that's the posterior point here where your posteromedial bundle would come in. So what are the graft choices here? You can use autografts or allografts. Allografts are most commonly used in PCL reconstructions as they provide sufficient graft strength, no donor site morbidity, it reduces the operating time. Allograft options, the best one, as we know, is a Achilles tendon allograft with calcaneal bone plug, which is the most preferred one. It provides a large volume and can be used in multi-ligament scenario, but it has potential risks of disease transmission, delayed healing, loss of graft strength, and tunnel widening. So one should be aware of. I think, are started getting these ligaments in Mumbai now. Autograft options are BTB, hamstrings, cot tendon, and recently peroneus longus. So Lin probably suggested that BTB has got a little greater complication rate as regards the osteoarthritic changes and posterior draw laxity. Whereas when hamstrings were compared, they found no significant difference in post-operative stability. And cot tendon autograft had revision rates or complication rates and functional outcomes which were comparable to other grafts. So I think probably hamstrings, cot tendon, peroneus longus, all grafts do as well as the other ones. According to a 2018, which is probably not the recent data, but they say that autograft patients had a little higher complication rate, and that is why probably the allografts were considered. But we can say that the surgical decision making should be based on surgeon's preference of the graft and comfort level for harvesting the same. Technique wise, we know that it's a Rob Laprade's technique again. So these are the operative steps. Graft choice. Here I have used peroneus for ALB and CEMETI for PMB with different diameters. The steps are graft harvest, diagnostic round, and all the same which I had said in a single bundle PCL. I will not repeat them. So this was the patient. He had ACL avulsion. The ACL avulsion was fixed, but the PCL was missed. And that's how there is a posterior drawer now. That's the SAC test. That's the SAC test there. And this patient, we used a 9 millimeter peroneus longus and a 7 millimeter CEMETI graft for doing a double bundle reconstruction. So again, the steps, they remain same. That's the sloppy ACL. ACL does not look very healthy. Middle-aged person. So we thought we should only do the PCL in this case, as the ACL was already fixed with a screw. We thought of not touching ACL at all at this point in time and take a call on ACL at a later date. You can see the PCL is completely attenuated. It's completely defunct PCL, no fibers left. Again, we revise the anatomy, trochlear point, that's the ALB, medial arch point and a posterior point. And then with a radio frequency probe, you normally mark where you want to put your tunnels. So I am making or marking something for the anterolateral bundle, and that's going to be about 4 millimeters where I'm going to put my posteromedial bundle. So with the radio frequency, marking these areas makes life a little easier. Then you have to space them apart so that you have an adequate bony bridge and you do not have a tunnel coalescence. We measure it with a scale. So that's about 4 to 5 millimeters. That's about 2 to 4 millimeters. So that's exactly the place where you want to put your tunnels. So that's the definitive size reamer, 9 size reamer, as we have 9 peroneus longus. And then on top of that, you drill the bit pin. Then you drill the definitive size tunnel there, which is 9 millimeters. Here I have used the interference screw fixation for a double bundle PCL, shave off certain remnants, then go on to the mark, put a 7 millimeter reamer and ream your posteromedial bundle tunnel. So that's the posteromedial bundle tunnel. Place 2 different colored sutures in different tunnels so that you know which is your anterolateral, which is your posteromedial. You can see that there is a nice bony bridge between the 2 tunnels, and the tunnels are placed in anatomical position. Again, posterolateral, posteromedial, 15 millimeters below. You can see the tibial tunnel. Same principles used with the jig. That's the bit pin coming out. Now here, once you have definitively drilled the size, that's the way you do it. You can use a curette, pass a passing shuttle, which comes out of the posteromedial portal, and then you shuttle these sutures into the anterior aspect, because in this situation, what we are going to do is, we are going to pass the femur first, and we are going to take the graft into the tibia after we fix it into the femur. So first the anterolateral bundle goes in. Because it is color-coded, we know what to push in first. Always have a guide wire there and a bio screw of the same size or a 1 size up is used to fix the anterolateral bundle. In the similar fashion, the posteromedial bundle is fixed, and both the bundles are now shuttled through the tibia to the anterior aspect or anteromedial aspect of the tibia and is fixed in similar position. Here, fixation needs to be differential, the anterolateral bundle and posterior medial bundle, to achieve a proper knee kinematics. So several studies have found double bundle reconstruction to be biomechanically superior to single bundle. Some studies significantly showed improved results after double bundle compared to single bundle when examining postoperative posterior laxity and posterior drawer. Although in a recent meta-analysis by Lee, this review found no significant biomechanical difference between single versus double bundle group with respect to external rotation, varus rotation, or coupled external rotation of the tibia with posterior drawer force at any knee flexion angle. So I think I will conclude by saying, although double bundle PCL looks more promising, the evidence suggests that single bundle PCL has similar outcomes. The ideal graft is yet to be derived at. Allograft has its own issues. Biomechanical advantage is yet to be translated into patient-reported outcomes. One should perform the surgery at each one's discretion of individual graft choice and reproducible technique to achieve patient satisfaction. I thank you for your attention.
Thank you, sir.
Thank you, sir.
Hello.
Yeah, Miten.
So,
Yeah, I was waiting for Mohan Kumar sir also.
Excellent talk, sir. Milind, sir.
Thank you,
Precise
thank you.
and point to point, very well explained. Thank you very much, sir.
Sir, why, in your personal preference, you prefer the soft tissue grafts more than the BTB, right?
Right, correct.
Do you think that's also related to the fact that soft tissue grafts you think are easier to negotiate through these tunnels? That's the only reason why you won't use the BTB?
So rather than convenience, I have not found any literature support where it says that either a cot tendon with bone plug or a BTB fare superior apart from their healing potential. They heal earlier to the tunnels.
Right.
So, and at the same time, as I said, convenience of graft harvest.
And one question I wanted,
Yeah.
I don't think it's asked enough. If you use a BTB bone block,
Yeah.
do you then need 2 bundles?
So, do you have any study in mind where they've said that? So I have not come
I have
across
nothing
any.
in mind. That's why I'm asking, just out of experience and logic, actually. In fact,
So I
not
think we are
only
trying to extrapolate logic of ACL to PCL.
No,
But-
sir. If you do a bone block, it covers a bigger footprint.
Right.
But it's just single bundle, right?
Exactly.
So do you think it fares worse than the soft tissue 2 bundles?
So your logic is only regarding covering of the footprint area, which is true with ACL. You have to cover more than 80%. There are no studies saying that PCL you need to cover so much of footprint.
so
So this study was done by Rainer Ziebold and Laprade group, ACL study group, isn't it?
Right, sir.
Yeah,
Neha,
but that
you
was
were saying
regarding
something.
ACL. I don't think it is regarding PCL.
So what are your indications for double bundle and what are your indications for single bundle?
So I do not do double bundle PCL reconstructions, to be honest. This was done, I did this case because there was a topic given to me for presentation in one of the conferences. My preference is still single bundle. And I am a follower of Strobel. I still use hamstrings wherever possible.
So with simultaneous ACL and PCL, what are your graft choices?
So presently I will use peroneus longus for my PCL and hamstrings for my ACL.
Okay.
So Miten, to answer your question, I'll just take that further with Miten for a bone block, as he was saying. So I think 2 bundles function co-dominantly that we know now. Initially, we were saying that they work in reciprocal way. But if they are going to work co-dominantly, that means they essentially are one bundle.
I didn't get the use of words. I'm sorry, but
So
this
it is, I'll
dominant
tell you.
word doesn't make
No,
sense.
I'll tell you. I'll explain it to you. See, two bundles are inseparable. Inseparable, correct?
Yes.
Hmm.
Yes.
We see two insertions. We see two insertions. But both the bundles work codominantly. Only posteromedial bundle, by virtue of its orientation of the fibers, works beyond 90 degrees of flexion to prevent external rotation or resist external rotation. Now, do you get it? Miten, where I'm not seeing you.
He's unmuted.
Unmuted. Yeah.
Yeah.
I got the logic that they are unlike in the ACL. Nothing is contributing more in flexion or more in extension. They're both essentially doing the same things.
So
Only the
PCL also
attachment.
essentially doing the same thing, except for
Hmm.
posteromedial bundle coming into play beyond 90 degrees to resist secondary function of external rotation. There are other restraints for external rotation. So how important that PMB is, one needs to understand. And if they are inseparable, then they are essentially one bundle. Then the logic of ACL should be applied to the PCL. The question will needs to be answered. Yes, I think we
Right.
should answer that question in due course of time.
Right, sir. Super. Any other questions?
Regarding the
Move on to the
postal
next
portal,
case.
sir, is
We
it
can move on
necessary?
to the next
Yeah,
part.
Sridhar, you were saying something?
Nothing, sir. Regarding the portal, so is it always necessary to put posteromedial and posterolateral, or posteromedial should be fine?
It should be fine. It is again individual preference. Why I take posterolateral is because I get a lot of space. Second is I am used to seeing knee from the lateral side. So my dexterity remains the same. I am more oriented. My cerebral cortex is more oriented with seeing knee from the lateral side. High posteromedial and low posteromedial, at times you'll see it is a mirror image. So you
Yeah.
have to imagine the PCL at the back of the knee. Here,
Yes.
you know, back is back, front is front. So that is easier to negotiate. And you get a lot of space there, you know. So there is hardly any chance where you can really, if you really wish to injure, you will injure probably.
Thank
And
you, sir.
it
Thank
doesn't
you
take
so
much
much.
of time as well, isn't it?
Yeah, yeah, yes. Thank you, sir. Thank you.
Next, I call upon Dr. Rohit Kulkarni
Yes,
to
sir.
give us a talk on repair of bucket handle tear of meniscus.
Good evening, everyone. At the outset, I would like to thank the respected committee members of IS for this wonderful opportunity. This is my first webinar, so I'm a little nervous, but I'm really grateful to have had this opportunity. Thank you, Neha ma'am, for the encouragement. I really appreciate it. So I'll just share my screen, sorry. So is the presentation visible to all?
Yes.
All right, so I'll be talking in brief about bucket handle medial meniscal tears. And after such a fantastic presentation by Pimprikar sir, I think my presentation is going to look very ordinary, but I'll still try my best. So moving on, I'm not going to go into too much details of the anatomy, but we all know that the meniscus is a specialized fibrocartilaginous tissue with mainly type 1 collagen. And it has got circumferential fibers, radial fibers, and some superficial randomly oriented fibers. So there are different zones of the meniscus depending on the vascularity. And we all know that there's a red-red zone, the red-white zone, and the white-white zone. The potential of healing of repairs done in the red-red zone is higher, obviously, as compared to those in the white-white zone. And studies have suggested that failure rates as high as 70% at second look arthroscopy after repair of radial and oblique tears, which were predominantly in the white-white zone, not extending into the red-red zone. So these are the different types of meniscus tears, but today we are going to mostly discuss about the bucket handle tears. So these are a subtype, I would say, of the longitudinal tears, which later on progressed to bucket handle tears. So basically, they are a subtype of just one second, please. subtype of the longitudinal tears, and they extend longitudinally in the body and extend anteriorly as well. The frequency of bucket handle tears has been reported between 9 to 26%, more common in young and middle-aged adults, with more of a male predominance, with a 76% predilection for the less mobile medial meniscus, and there is a strong association with ACL tears. Looking at the signs and symptoms, I think the most prominent here is an ability to completely extend the knee joint, and that is probably because of the flipped meniscal fragment, which is lying in the intercondylar notch. There can be an associated instability like we saw. There could be associated ligament injuries. Sometimes the fragment can get reduced on its own. That is called as a spontaneous reduction, but very few cases have been reported in the literature. So there is a classification which is called as Dandy's classification. So type 1 is a complete tear, which extends along the entire length to within 1 centimeter of the anterior insertion. Type B tear is one in which it extends up to the anterior root, but not involving it. Type C and D are called as broken bucket handle tears, where there can be a retained posterior attachment or an anterior attachment respectively. I think this is something that we should all remember, that there are almost 6 signs of bucket handle tears. So the first one is an absent bow tie sign. So if we look at 2 sagittal images of an intact meniscus, let's say an intact medial meniscus, you would see something of a bow tie. Whereas in cases of a bucket handle tear or a longitudinal tear, which is with a flip fragment, you will see that there is a break in it, which is called as an absent bow tie sign. Double PCL sign, I think we all know, wherein the flipped meniscus acts as the second PCL apart from the native PCL. This may not be there always in cases of bucket handle lateral meniscus tears. The flipped meniscus sign, wherein you may see that there is a shortened posterior horn and comparatively an elongated anterior horn, and that is because of the flipped fragment as well. A fragment in the intercondylar notch sign, wherein a band-like area of low signal tissue is lying within the notch, but not in the same slice as that of the PCL. The double anterior horn sign, I think we do see that commonly in bucket handle tears, wherein the solid arrow is indicative of an intact anterior horn, whereas the dashed arrow is indicative of the flipped meniscal fragment. There's something which is called as a disproportional posterior horn sign, wherein the posterior horn appears to be shortened as compared to the anterior one. So MRI is a proven accurate method to non-invasively diagnose bucket handle meniscal tears. Probably the absent bow tie sign and the displaced fragment sign have a good sensitivity, whereas the double PCL sign has got a very high specificity, especially for medial meniscal bucket handle tears, going to up to almost, in some studies, 100%. So MRI assessment of repairability have been described, but I think they are better to know theoretically rather than practically. Nevertheless, Thorio et al. Have described them, wherein a peripheral rim segment less than 4 mm wide, a tear length of 1 centimeter or greater, and minimal damage to the inner and peripheral meniscal fragments make it more amenable for fixation. Repair technique in a bucket handle tear is important because you might have to come up with a combination of techniques. So be wise in the technique that you choose. So for posterior horn, you can choose an all inside kind of a repair. For the body, probably an inside out kind of a repair. And for the anterior horn, you can choose something which is, kind of an outside in kind of a repair. So this was a good arthroscopy techniques paper, and they have described 10 pearls for bucket handle medial meniscus repair, something which I felt that we can reproduce easily in our day-to-day practice, right from patient positioning, and I think this is how we all position our patient, probably keep an NS bottle at 90 degrees of knee flexion. Standard portal placements, maybe an extra additional transpatellar portal may be required if you are doing an outside in kind of a repair for the anterior horn. And you do get a good visualization with your standard portals. Evaluate the tear properly and then reduce it with the help of an obturator or with the help of a probe. MCL pie crusting for me is the most important step for allowing it, I think visualization is extremely important while repairing these tears. And you can take an 18 gauge spinal needle after doing your surface anatomy markings, and you can release the MCL somewhere near to its, closer to its femoral attachment, and you get a nice opening of the medial compartmental space. So this is important to avoid iatrogenic cartilage damage. Regarding the meniscal wall cruentation or just trying to get some fresh bleeding, you can shave off the perimeniscal synovial tissue and you can rasp it. So this is how I normally do. After shaving off the perimeniscal synovial tissue, I kind of use my diamond rasp, which is there in the set, and you freshen the edges. Repair technique, like we saw, choose your repair technique wisely, and tying of the inside out knots. I think we can take a small incision, 3 to 4 centimeter incision upon the posterior medial aspect. That will make your life easy. The incision should probably be taken with the knee in 90 degrees of flexion so that the neurovascular structures, especially the saphenous nerve, it goes posterior to the joint line. The popliteal bundle is of course posterolateral, so it's going to be away anyways. And you can use a normal autoclaved spoon to sort of withdraw these needles, which are mostly flexible needles. And this is something that we can use. The safety incision, as described by Tapasvi sir and published in the Asian Journal of Arthroscopy, is a 3 to 4 centimeter incision, which is taken in the posterior medial aspect of the joint. So this is for the medial meniscus, which I'm talking about, posterior to the MCL, made with knee in 60 to 90 degrees of flexion, wherein the hamstrings are retracted posteriorly and a plane is developed between the medial head of the gastroc and the posterior medial capsule. Moving on to the cases, the first case of a 33-year-old gentleman with a alleged history of twisting injury to the left knee. He complained of pain as well as instability. So he had anterior drawers, which was positive, a Lachman's, which was positive, and a range of motion of around 10 to 130 degrees. So we can, this is his MRI, and we can classically see the double PCL sign here. You can also see a double anterior horn sign with the flicked fragment going anteriorly and a shortened posterior horn. We can also see, in the coronal images, we can see a part of the meniscus, which is lying in the intercondylar notch. Moving on to the video. So this is the flipped portion of the medial meniscus, which is lying in the intercondylar notch. You can reduce this flipped portion with the help of a probe or with the help of your obturator. Then you can do some gentle pie crusting and try to open up the medial compartment. Sometimes opening up the medial compartment might cause the meniscus to jump back. But, in that case, if it is unstable, you can take a traction stitch, or you can just hold it in place by taking another portal and introducing something like a probe. So the first stage which I take is normally at the junction of the posterior horn and the body of the medial meniscus. This acts like, this helps in reducing the meniscus, and it acts like a holding stitch. Kindly allow me a moment, please. Am I audible? Sorry.
Yes, we can hear you.
I'm extremely sorry for this small break. So once we have got this reduction stitch in place, it will help to hold the meniscus. Many a times there is a bit of upturning of the meniscus while taking this stitch, and I will address that later as I show you subsequently in the video. Once you get that stitch in place, you can then turn your attention towards repairing the body of the meniscus. So you should have your armamentarium ready, and you should have the zone-specific cannulas ready. So you can use the flexible meniscal needles. While using this, you can either choose a horizontal mattress or a vertical mattress, but a vertical mattress is always biomechanically more superior as compared to a horizontal mattress configuration of your stitches. So once you take the meniscal needles, one goes through the capsule and the other one goes through the substance of the meniscus, and it kind of holds it in place. You can retrieve these medially, and then you can take multiple stitches across the body of the medial meniscus. So a vertical mattress configuration, which I'm taking here, and again, I'm trying to take more stitches across the body. I'll move ahead slightly. So once I've done that, I'm then going to turn my attention to the upturned meniscus, that is the posterior horn of the meniscus. For this, the easiest way I feel is, to bring it back into place is by taking an undersurface kind of a stitch. So for this, you can use your all-inside device and take a couple of undersurface bites. This is going to be more like a horizontal mattress kind of a configuration in the undersurface of the meniscus. Once you have taken your undersurface stitch, make sure that you hold the meniscus in place with the help of your probe and be very gentle while you're tightening the meniscus. And once you are happy with it, you can see that the meniscus now sits down nicely over the tibial surface. After that, you can just cut off the knots and then turn your attention towards repairing the body and taking more stitches in the body of the meniscus. Here I have taken a flexible all-inside device to get a more robust repair in the body as well. So one bite which is going through the capsule and another bite which is going through the substance of the meniscus. And then again, be sure that you introduce your probe and you gently, kind of hold the meniscus in place as you're tightening. Make sure that you don't over tighten it or over tension it. Otherwise, it can cause a bit of meniscal extrusion. So the other knots are not tied yet, so they appear to be a bit loose. But you can complete your repair by taking. So I'm just kind of pulling it in, and it seems to be falling in place. You can then complete your repair by taking a few more vertical mattress bites. So surprisingly, a bit of literature search showed that only 24% of surgically treated bucket handle meniscus tears were treated using a repair. Identification of patients, socioeconomic and hospital factors, different factors contributed to it, probably socioeconomic as in a lot of armamentarium is required, a lot of material is required in the form of all-inside devices. Inside-out meniscal needles are something which is something which we can use probably is less is more economically viable. You can also use a reusable meniscal needle in order to reduce the cost and a fiber wire. Also, repair of a displaced bucket handle tear of the meniscus can be technically challenging, and preservation of the meniscus should always be considered as the first line of treatment because after a partial meniscectomy, inferior clinical results are there. This is another case of a 19-year-old boy complaining of right knee pain. So he was having a McMurray's test, which was positive but painful, a anterior Drawers test, which was positive, and this was his MRI scan. Again, you can see here a flipped part of the meniscus, which is lying next to the post PCL and giving, the appearance of a double PCL kind of a sign. So many of these, like we discussed, are associated with ligament injuries. So this was again an ACL tear along with a bucket handle tear of the meniscus. Once you repair your meniscus, so in this case, I have used a kind of a horizontal mattress kind of configuration. Sometimes we tend to do it for, to save some surgical implant cost. However, ideal would be taking, I'll just mute this. So, but biomechanically, I would say vertical mattress stitches are much biomechanically superior. So again, in this case, I have taken multiple bites in the body, and probably one advantage is that it spans a larger area of the body of the meniscus. If you're taking a horizontal kind of a configuration, and then you can take an all-inside device in order to repair the posterior horn of the meniscus. And once you're done that, I think you can just use your probe and hold it in place and tighten
Hi,
your.
Rohit. Sorry to cut you short. We are running late on time. It's 9 o'clock already.
Yes, sir. Yes, sir. I'm just wrapping it up.
Yeah, but just want to make a
It's
note just before you continue. I'm
yes.
sorry I need to leave the webinar because I had scheduled time till 9. But maybe a note to presenters or to the organizers, Neha, Sridhar.
Yes, sir.
I think this is wonderful and we can learn so much out of cases. But there must be a sort of an informal rule that you start with the case presentation directly so that we can discuss so much on the cases. The background information to the case presentation as such generally kills time. And then, see, there are so many questions I would have loved to ask regarding the case that you presented itself, but
Okay,
then
sir.
we miss out on those. So
Okay, sir. Okay, sir. I'll
maybe
keep that
all
in
the
mind. No
case
problem.
presenters can be requested this. Please carry on. I'm so sorry. And
No problem, sir. Thank you. Thank you for your input, sir.
yeah.
So I'm almost towards the end of it, and this is after the repair. So going ahead, just last minute I would take a 25-year-old gentleman, and he had got an anterior and a posterior drawer positive, and the MRI showed a flipped portion of the lateral meniscus and an ACL and a PCL tear with a bucket handle tear of the lateral meniscus. Unfortunately, I don't have a video of this, but I've just made serial pictures wherein you can see the torn lateral meniscus flipped in the intercondylar notch. So it is easily mistook. You can easily mistake that for for the ACL, but you have to be careful in your pre-op planning. And this is how it looks like after reduction. And then you can take all inside stitches in the posterior horn and the body, and in the junction of the body and the posterior horn. Here I've used a combination of techniques where I've used an outside in kind of a repair for the anterior horn. So a nylon thread first, and I've reloaded a fiber wire later, and then another vertical mattress sutures for the body. And after which I completed my ACL and the PCL. So I used the peroneus longus for the PCL reconstruction and the hamstring tendons for the ACL. Thank you so much, and my apologies for for the short delay in between. Thank you so much.
Thank you, Rohit. Thank you for that wonderful case presentation. So now I'd move
Thank you, sir.
directly to the next case presentation. I would invite Dr. Ajinkya talk about his triple trouble knee.
Yes, sir. Sharing my screen. Is my screen visible?
Yes, sir.
Okay. So I would like to thank IS for giving me this opportunity, and especially Dr. Neha ma'am for encouraging me to go ahead with this presentation. So I'll start with my presentation directly. So this is a 22 years old gentleman, had a road traffic accident, especially fall from bike, injured left knee, and started complaining of pain and swelling. He has a difficulty in walking after injury, and mostly settled by taking medications from a local practitioner. After 7 days, he was able to walk, but he was limping and also complaining of instability. So after 7 days, when I have evaluated him, so he started complaining of the tenderness over the middle and the lateral joint line. The batellar tap was positive, significant enough to mainly the effusion. His knee ROM was significantly reduced, just 0 to 60 degrees. The Latchman test was positive, and I was not able to assess the anterior drawer and the pivot shift because of pain and the inadequate ROM. The valgus and varus tests were negative. So these are the X-rays of that particular case. So in this X-ray, you can clearly see there is some kind of a tibial eminence fracture in the proximal tibia, in particularly. I advised him to get the MRI. So these are the MRI findings, where you can see the lateral meniscus. There is some kind of avulsion on the particularly the coronal images. In the sagittal section, you can see clearly the tibial eminence is elevated. I'm also not able to see the particular insertion of femoral insertion of ACL, which was very doubtful. So these are in detail pictures of the particular sagittal sections of that particular MRI. So the significant fragment of tibial, particularly plateau, we can clearly see in these images. And also, if you trace the lateral meniscus, particularly the posterior root, is looking like sort of avulsed. So this is just a small diagnostic round. So in this case, so I was just particularly concern about the posterolateral bundle, and this particular area where I was not sure whether the particular posterolateral bundle is quite firmly attached with the femoral footprint or not. So in order to rule out that the PL bundle is injured from the femoral side, I just did the figure of 4 position and moved my scope in the anteromedial portal and assessed the femoral footprint. So the tissues were very lax on that particular PL bundle side. So at that moment, I decided that we'll definitely require a PL bundle also to reconstruct. Also, the lateral meniscus posterior root was pretty much unstable, and I was able to completely elevate it. Also, you can see some kind of a particular bruising on the lateral meniscus. Elsewise, the lateral meniscus and the medial meniscus and the other ligaments were intact. So this is how I planned. So I've decided to do ACL avulsion fixation with the help of CC screw or pull-out sutures, and the lateral meniscus root repair with mainly the pull-out sutures, and the arthroscopic PL bundle reconstruction using SEMITI. So this is the particular video of what I have particularly done. So this is the big fragment of the PBL plateau. So I've refreshing all the particular crater. Being a significant fragment, I've decided to go ahead with the fixation with the CC screw. So first of all, I've reduced the avulsed fragment. So it is very important to look for the reduction of this avulsed fragment, as the transverse meniscal ligament tries to particularly come between the fracture fragment reduction. So you have to take care of that particular transverse meniscal ligament that you should elevate and reduce the avulsed fragment completely with the tibial plateau. After this reduction, so I've just inserted the guide wire and a K wire, and then insert a 4mm CC screw for the fixation. After this, I've moved ahead with the fixation of the, this is the picture, C-arm view. After this, I move ahead with the femoral tunnel creation for a PL bundle reconstruction. After the femoral tunnel creation, I moved ahead with the taking sutures through the lateral meniscus root. So my sequence was like this: first do the fixation of ACL avulsion, then the femoral tunnel, and then the lateral meniscus root stitches and the tunnel for the lateral meniscus root pull-through sutures. Then I did the tibial tunnel for the PL bundle, making sure that the anteromedial bundle is not particularly injured while turning. This is the final picture where the posterolateral bundle is very well reconstructed. I've noticed some sort of impingement, so did a notchplasty for the lateral femoral condyle. And at last, I've fixed particularly the pull-through sutures of the lateral meniscus root. So this is the final arthroscopic picture where the anteromedial bundle, original native, is there, and along with the reconstructed PL bundle. This is the arthroscopic, this is the radiograph taken after the surgery. The tibial tunnel was quite anterior, but the fixation was pretty much stable. I've assessed intraoperatively. So the rehab protocol in this particular case, I've kept the patient nail weight bearing for 6 weeks, followed by the knee ROM 0 to 30 degrees for the next 2 weeks till suture removal. And 2 to 6 weeks, I've increased the knee ROM gradually. Considering it as an avulsion, I've moved gradually. In from 6 to 12 weeks, I started with the increasing the knee RM as well as strengthening of the quads. After 3 months, I started with the functional training and gradually returned to work. Now patient is back to work. This is the fresh X-ray. This is the just X-ray which I got just last week, where we can see the particularly the eminence has completely healed. There are no particular signs of any kind of impingement. Patient is a security guard by profile, so he is back to his routine activities, absolutely fine. So just the last 2 slides where we can see in literature it is reported that it is possible that avulsion as well as the tear of ACL is possible. So this is a case report where they have reported the tibial spine avulsion along with the anterior cruciate ligament tear. Also, I have particularly like to mention this famous paper by Sonri Kotet, where he has particularly assessed the posterolateral bundle and means where the only posterolateral bundle was torn. So he has specifically mentioned that you have to take the decision to do posterolateral augmentation at the time of arthroscopy only. The the figure of 4 position assessment is very helpful. So that's my presentation. Thank you.
Thank you, Ajinkya. Oh,
Yes.
very rare case presented very well and with a good result at the end. Thank you. Thank you, Ajinkya.
Yes. Thank you, sir.
Any questions? Sridhar, sir?
Fine. Any plans for removal of the screw or anything?
I have advised him, but being a security guard, he has some financial issues because for removing the screw only, I was planning to go arthroscopic. So I advised him if he has any complaints, then definitely he will come back.
Did you think of pull-through sutures for this? For ACL?
Yeah, pull-through sutures was the option, but the fragment was significant enough, as we can see on the particular X-ray as well as on an MRI. So I thought the much more stable fixation would have been a screw. So that's why I've used a single screw was sufficient enough to particularly compress that fragment. So I have not added any kind of additional screw. The challenge for me was to drill a tibial tunnel because of that fracture scenario, because that imminence was there was not only a single bigger fragment was there, but I was of the particular worry that I should not particularly fracture that fragment and communicate it. So that was the most challenging part. The rest, otherwise, the particular fixation and passage of graft, everything was smooth.
Excellent case.
Maybe you're lucky enough that with the screw it didn't get communicated.
Yeah.
So that's
Thank you,
more useful if you're doing a tunnel technique like pull-through sutures. So either
Yes,
single
sir. Yes,
tunnel
sir.
or a double tunnel, you can
Point
do
well.
that. So you can balance the fragment medilaterally and keep it. And usual only advantage is that same screw inside the joint. Sometimes it may get buried and difficult to remove. Sometimes it
Correct,
may be
sir.
poking into the joint. So those hardware issue things we can avoid. Otherwise, it's an
Yes, sir.
excellent fixation.
Yes,
Thank
sir.
you.
Yes.
Thank you so much.
Thank you. Thank you for the input,
Thank
sir.
you. Yeah, thanks.
If there are no questions on YouTube chat also, I've
Yeah,
liked
ma'am.
also. So if there are no questions, we can end the session. It was a wonderful session. Dr. Pimplikar sir, thank you, Dr. Mohan Kumar. If you have any final comments, you can tell us, sir.
It was wonderful, well organized, and all the topics were very good. Thank you for having me as a moderator. Thank you.
Thank you, sir. Thank you.
Okay.
Bye.
Yeah.
Thank you,
Thank
Rohit.
you.
Thank you, Ajinkya.
Thank you, ma'am.
Thank you, ma'am.
Yes.
Thank you so much. Thank you, IS. Thank you.